line.
So, agenda item number 1, included in your packets are copies of the minutes from December 14th, 2023 and December 21, 2023, public meetings of the Commission that took place in person and by video conference. I will now entertain a motion to approve those minutes. So I have a motion to approve the December 14th and December 21.
I'll make a motion to approve.
Thank you, Commissioner Buzinski. So second. Commissioner Douglas.
Second.
Does anyone have any comments on the minutes? All right. All in favor?
Aye.
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 Are there anyone opposed? Minutes carry. Now, it looks like before we go on to agenda item number 2, do we have internet back?
No, we're broadcasting from
Okay.
the room can see it. I don't think anyone else cannot. So.
I won't discombobulate the arrangements then. Okay, so the way it is now, everybody can. And now see it inside what you're saying. So everybody now can see the presentation. Okay, great. So it's just the video feed and making sure that we're loud enough on the speakerphone for the people online. Okay. Agenda item number 2 is an update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Mr. Executive Director, can you do you have any additional updates that were not included in the monthly updates?
So I'm going to try to speak as loud as I can. The first update that I have. The governor's budget was announced yesterday. The commission budget is part of that submission, and we're happy to note that what we had requested is actually the figure in the governor's budget. It includes $20 million for our operating activities, as well as $13 million for the trauma fund, and for we do make a transfer from the MSOF fund to the University of Maryland Shock Trauma. That was included for a value of $3.7 million. The total MHCC budget, of which 20.1 is operating activities, is $36.8 million. The commission will present its budget to the House Appropriations Committee next February 15th, which happens to be the regular date of a commission meeting. We will be in touch with all commissioners to look at the feasibility of moving that commission meeting to the 22nd, which is the following Thursday. I think the hope is that we could meet at the regular time, but another option is at 9 o'clock in the morning that day. Also, you may recall that I previously announced that in February we would be distributing Microsoft Surfaces, through which we would be sharing the commission monthly agenda documents. That training is still being planned, but we'll be back in touch with you on whether it's going to be before or after the meeting. It will depend on whether we start the meeting at 9 o'clock in the morning or 1 o'clock as we usually do. A survey will be sent out to all the commissioners to get your availability. I apologize for the change in plans, but when the legislature calls, we should respond and appear before them to explain the commission's activities and budget. A couple notes: the reports that were presented and approved by the commission in December have now been shared with the legislature. They are posted on the website. There are 2 outstanding reports, actually 3, that we need to have action on today. The first is the report on small assisted living that's going to be presented later. And a second is the mandate study on hearing aids that our consultant will present as well. The third report is actually not one that needs to be approved, but it is to the legislature on the recommendations of the Commission on Trauma Funding, of which MHCC and MIMS staffed it. That does not require a formal approval, but it would be shared with you as soon as it's ready for release. That will be sent to you via email either later today or early tomorrow morning. I'd also note that another requirement that we had been given was to recommend how $9.5 million in additional funding should be distributed to the Maryland trauma centers that were under stress. We have met several times with the group that would be eligible to receive these funds and have concluded that basically all trauma centers are under some stress because of the the incremental cost, principally related to clinical and nursing staffing that's required as a result of being a trauma center. So we are proposing to distribute that funding approximately on equal shares, but based on three specific variables. One, each trauma center, based on the fact that our trauma center would get a portion of those funds. About 50% of the funds would be distributed in that manner. The remaining 25% of the funds would be divided two ways. One, based on a categorization of that trauma center's injury severity index scores, which would award more money to trauma centers that had more complex patients. And the third category would be to divide it inversely related to the complexity of the trauma center. The thinking being here that the lower level trauma centers have readiness and availability costs regarding the provision of physicians, but they actually don't have as much volume. Nonetheless, the requirements of our trauma center standards require physicians to be available. So 25% would be distributed based on the lower levels of trauma centers on the thinking that they don't have as much volume. They can't recover funding through billings, and therefore it makes some sense to provide a share of funding in that way. Basically, everyone would be receiving about $1 million from the fund. Tomorrow we will meet with budget officials, budget and management officials, to review that with them, and we'll send out a formal notice to commissioners on the plans for this distribution shortly. The next step after this is reviewed with the Secretary for Budget and Management is that we have to send a letter to the respective appropriations committees, Senate Budget, House Appropriations, telling them what we do. And so we probably would not bring this formally to a vote for the commission until the February meeting, because they requested 30 days or 45 days advance notice before any funds would be distributed. So I think the appropriate time for the commission to take action on this is in February. But I will share what the plan is tomorrow. That concludes my abbreviated summary, recognizing the difficulties. We'll try to move through this a little more quickly. A couple other notes I'll share with you at the conclusion of the commission meeting. Hopefully we'll be live.
Any questions for the Executive Director? That we could go on to agenda item number 3.
I think we have one introduction here that was kind of late entry. not under, it's like just really. You probably need to speak really loud, or come up here.
This is Eileen Fleck. Number in my. Joining NHCC.
Welcome. What might make sense,
I think someone should
while we
come
have
up
the
here.
phone? Yeah, do you want to move over one, and I'll move over one, and then we've got 2 seats for...
Can I vote?
You can hold the gavel if you like. Okay. Alrighty, agenda item number 3, certificate of need, the relocation of Shore Medical Center at Easton Shore Health System. University of Maryland Shore Health System has applied for a certificate of need to build a new hospital to replace the existing University of Maryland Shore Medical Center in Easton, Talbot County. The replacement hospital will be located 3 miles from the existing facility with a projected cost of approximately $539 million. Program Manager Maura Lawson will present the staff recommendation. Myra, please proceed.
Thank you, Chairman Sargent, and good afternoon, Commissioners. Before the Commission today is a request to relocate and replace the University of Maryland Shore Medical Center at Easton, a general acute care hospital operating in downtown Easton, to an undeveloped site approximately 3 miles from the existing campus. Shore Health System, Inc. is the applicant in this review. Shore Health System operates the University of Maryland Shore Medical Center at Easton, as well as 2 freestanding medical facilities, or FMFs, 1 in Cambridge and 1 in Queenstown. The applicant also operates a number of outpatient facilities in Easton, Denton, Cambridge, and Centerville. Shore Health System stated that the existing hospital is outdated and obsolete, and also undersized after the movement of beds to Easton following the conversion of the University of Maryland Hospital in Cambridge to an FMF. Additionally, the existing campus is located in a residential neighborhood that limits any expansion and creates access issues for both patients and staff. The proposed replacement hospital will include 110 beds, 12 special hospital rehabilitation beds, and 25 observation beds. The hospital will also include an emergency department with 27 treatment spaces and 3 behavioral health holding rooms, regulated outpatient clinics, a full-service laboratory, and space for administrative and education functions. The estimated cost of the project is $539.5 million, and Shore Health System proposes to finance the project with $39 million in cash, $50 million in philanthropy, $333 million in debt financing, $100 million in state funding, and $18 million in interest income. Due to the scope of the project, the applicant was required to meet standards in a number of the chapters of the state health plan, as well as the certificate of need criteria. Chapters include acute hospital services, obstetric services, general surgical services, acute inpatient rehabilitation services, and psychiatric services. While relocation to the replacement hospital will not change the scope of services being provided to patients in the service area, the new facility will be right-sized to improve access and efficiency. Examples of improvements at the replacement hospital include a change to only private rooms from predominantly semi-private rooms, and also in the new hospital, all rooms will have ECG monitoring, where only a portion of them do in the hospital currently. The new hospital will have a dedicated 25-bed observation unit, and currently observation patients are located throughout the hospital where room allows. The replacement facility will have a slightly smaller ED with 27 treatment spaces instead of the current 2, but it will have 3 behavioral health holding rooms, which they do not have at the current facility. Operating rooms at the replacement facility will be larger and will better accommodate technology needed for complex surgeries. As to the staff recommendation, staff concluded the applicant has successfully demonstrated the need for the project. This includes the need for comprehensive modernization of the facilities and for the services and capacities proposed by the applicant. Shore Health System has adequately demonstrated that the proposed relocation room placement is a cost-effective approach to the needed modernization. Additionally, the new site offers better access to residents of the service area. Staff found that the projected costs for the project were below that calculated using the Marshall Valuation Service Guidelines. Staff concluded the efficiency and workflow will be improved through the project. And finally, the staff concluded that the project can be both financially feasible and viable and will likely have a positive impact on patient safety and quality of services. Staff notes there is a correction on page 119 of the report, which has to do with the historic use rates of psychiatric services. This correction does not affect the staff's recommendation. Staff recommends that the Commission approve the application by the University of Maryland Shore Health System for a certificate of need with the following 3 conditions. Number 1, the University of Maryland Shore Medical Center at Easton shall provide, upon request, information concerning an estimate of out-of-pocket charges prior to arrival for surgery. Shore Health System, number 2, Shore Health System shall provide detailed updates on its progress towards obtaining all the anticipated funding, including how much has been obtained and efforts made to secure the remaining funds. And number 3, if Shore Health System fails to secure the projected state sources of funds by July 2027, the applicant shall request a project change to amend the project source of funds. Attending today for the applicant from Shore Regional Health are Ken Kozel, President and Chief Executive Officer, Paul Nicholson, Senior Vice President and Chief Financial Officer, Arvind Singh, VP of Strategic Planning and Communications. From KMPG LLC is Garo P. Gazarian, Managing Director, and also counsel for the applicants, Mallory Regenbogen and Allison Ludicher here. So thank you, and if there are any questions.
Welcome. So I'll start with, before questions, I want to start with a motion, put a motion on the floor. Do I have a motion to approve the CON for relocation of the UM Shore Medical Center at Easton Shore Health System? I think Commissioner Boyle on this one. Commissioner Boyle, do I have a second? Commissioner Buzinski has a second. Okay, are there any questions?
Yeah, this is Commissioner Mandari. I have a question. Actually, I have two questions. One is, I know it's a well-deserved project. The Shore Health used to have a cancer center, which was run by the oncologist there. And recently they have closed the cancer center. And that's one question, if they're going to relocate the hospital does has a cancer center, why it was closed. The second question is, I think, still I practice in Annapolis, see a lot of patients from Eastern Shore. The services in the hospital, there are specialists are not rounding in the hospital. They have no access to many specialists, and the care is a concern. Even building a new hospital, is going to be fixed or it's going to be an ongoing problem and issue?
Okay, I don't know. I think that these are questions best deferred to the applicant. So I don't know if
we have one of the, I think Dr. Bandari's first question pertains to the ownership of the oncology practice. I don't know who would be best equipped to answer that,
Yep.
but come
Uh,
forward.
Thanks, Ben. Ken, do you mind coming forward to address the first question? And then it's really hard for us to hear him back, so we'd love Dr. Bhandari to.
Yes, we can ask him to repeat.
Thank you.
I can repeat if you want.
Just one second. I think the first question is clear.
Yeah,
was,
why the
uh,
cancer center was closed and what is the position on the cancer center from the hospital?
Yes, sir. Thank you, Doctor. My name's Ken Kozel. I'm the CEO for the University of Maryland Shore Regional Health. I appreciate your question. To give a little background, Shore Regional Health offers two types of cancer services within our system. The first is radiation oncology services, and the second is medical oncology services. Both services are provided off campus, not in the existing hospital in Easton today. It's provided in a separate building about a mile from the hospital campus. It is still a regulated service, but we were allowed to relocate it because of the space constraints of the existing campus. So that's a little background. Now, one of the things we've done very recently was deregulate the medical oncology services that we offer on the within the system. We have deregulated that service, but we still have the regulated radiation oncology services. That's off-site. When we deregulated the medical oncology services, we created a relationship with Medical Oncology Hematology. That's a group that was formerly out of Annapolis that has taken up space here in Easton, in Talbot County. That relationship allows us to provide medical oncology services to our community who was formerly traveling to Annapolis to get that care. So we have been able to partner to a large extent with Medical Oncology Hematology. We've been able to expand the scope of services that we offer in our community and within our community so they don't have to travel outside to get that service. So that relationship is now a deregulated relationship, but they offer to our patients a substantial variety of medical oncology services now.
Just to make sure I understand, when you're saying deregulated, that means it's not treated as hospital space under the HSCRC, but it's not hospital space providing those services.
That's correct. It is not under the cap within the Shore Regional Health System with the HSCRC, but it is part of the service that we offer collectively as part of the healthcare system for the region.
So basically, actually, you outsource to a third party, although the cancer center was part of the hospital before, which was physically not on the hospital campus, but was about a mile. So that service has been outsourced to a third party. Was there a good reason? Actually, I can tell you, still many patients are getting treatment in Easton. Not everybody is coming to Annapolis. I still have been perplexed with the model where, it does create an issue. The patient who are underserved or uninsured before they was getting treatment in the hospital-based cancer center, where the care will be compromised. I'm very well aware of all the logistics which you have explained. It creates me a lot of concerns ongoing. Because, oncology is an integral part of the hospital system. When you outsource to a third-party venture capitalist company, which is, actually a Maryland Oncology is managed by US Oncology, which is a part of McKesson, you are giving a service line to a third-party venture capitalist. And obviously, it's a source of income for them, which hospital could have utilized for their patients and for their, revenue for the hospital.
I appreciate that perspective, Doctor. Our decision to deregulate the service line and create a relationship with Maryland Oncology Hematology was really predicated on the fact that it was incredibly difficult for us to hire and retain medical oncologists for our region. It got to the point where we had a part-time, only 1/2 of an FTE of a medical oncologist who did very, very limited types of medical oncology procedures and saw very, very limited patients in her service line, to the point where we felt that our community need was much greater and there had to be a better solution to keep our patients in our region and to allow them to get the care they needed locally. You're absolutely right, Doctor. There is another medical oncology service within the community, but there is no direct relationship with that private practice group. But having said that, there is still a significant need in our community for medical oncology services. This partnership, we believe, will help expand the capabilities and scope of services we can offer and keep patients local. From a financial perspective, they have assured us, and we have written letters to the community as part of this transition, that they have support services to help with financial aid and financial assistance, and they'll also support our patients with getting access to payers for medical assistance or Medicaid or any other payer that's necessary in order to qualify for payment for these services.
Thank you. And I heard there is no inpatient coverage for medical oncology, although you have outsourced to a big practice who has a number of oncologists. Don't you think they should cover hospital inpatient services also? This is an integral part of the, good hospital. There should be an inpatient. Doctors are coming and seeing patient in the hospital rather than just, in the office only, because the patient care is a continuity of care. Patients seen in the office need to be followed when they're admitted in the hospital.
I agree, Doctor. It is, and it is part of our long-term vision to establish that relationship for that level of care.
I hope it happens sooner rather than long-term, because long-term could be 6 months, a year, 5 years from now.
Understood.
Thank you.
Any other?
Thank you.
Thank you. Commissioner Buzinski?
Fine. Oh, don't go anywhere.
I was just gonna switch, that's all.
Ken Buzinski, Commissioner. On my time here at the commission, this is the first time I've seen a project of this scope for a new hospital, so I do have a question. Perhaps I don't fully understand. My understanding of rate-regulated space was for services that were inpatient services. Yet it sounds like you have a large clinic area for ambulatory outpatient services and lab services that is rate-regulated spaces. And it seems that care received in those areas tend to be much higher cost than in the unregulated free market spaces, whatever we call them, non-rate regulated spaces. So what's the rationale for including outpatient services in a budget and a project that's really a hospital project?
And I'll jump in after that, or?
Sure. Yeah.
Okay.
Oh, well, so, thank you for the question. I think part of it is that it all comes back to the financial picture. In some of the clinic services, in order to make them financially feasible for the hospital service area, have to be rate regulated. And I don't know if, Ken, you want to expand on that, or we could have Paul come up and expand on that.
What service lines will be rate regulated? Ambulatory service lines. Apparently oncology is not.
That's correct. There's a number of programs that are part of the regulated service in those clinics, infusion services.
Yes, infusion, I can pull up. Paul, do you want to?
Yep.
Sure.
Here you go, so I'll just move over here.
We're moving folks around. We are making sure folks are close enough to this telephone, which looks like the same technology with which we won the Cold War in the 1990s.
Almost forgot.
Good afternoon. Thank you for your question. Paul Nicholson, Senior Vice President of Finance for Shore Regional Health. It's an excellent question, and a question I seem to have to answer over and over again. The mix of regulated and unregulated clinic services often depends upon the demand for services and the type of services and how they're treated in the community. An example would be cardiac rehab is often in regulated space where patients come in after cardiac treatment for rehabilitation. It's a service that is not often approved by payers in unregulated space, so we offer it in regulated space. Pain procedures are often not financially viable in unregulated space, so we provide them in regulated space. It depends on the financial model. Let's see.
All right.
My helper is coming.
The binders came in handy, so.
There we go.
So the current regulated clinics are the behavioral health outpatient clinic, cardio rehab, diabetes, infusion center, pain management, sleep lab, multi-specialty, and an outpatient lab draw.
The mix of those services can be driven by payer mix, history, and demand for those services in the community.
have one comment I would like to make. I think I mentioned this last meeting with the expansion of the spectrum. Starting as a provider of obstetrics, I understand the need, and in a rural area, it's underserved. An issue directly with your application, but a comment I'd like to make about the standard imposed of a certain floor number of deliveries need to be performed in order to retain. I don't understand how that better serves the needs of a community or a population of pregnant patients. And argue we should look at whether or not that's valuable or helpful for the care of patients. I do applaud you all for continuing to provide obstetric services. I know it's a costly and high-risk area, but habit is incredibly high risk and high stress for the patients who are pregnant.
Are there any other commissioners that have questions or comments?
I do. This is Commissioner Blake.
Go ahead, Commissioner Blake.
I had two questions. One being around needs assessment with the community. Were there any activities around that with the community? I see a lot of feedback from the staff, but not much from the community. So that's my first question. And my second question is, I was curious to know or learn more about why the beds for pediatrics and obstetrics will be decreased in the new proposed hospital.
So I'll start with the needs assessment and the contributions to the community. Again, this is Ken Kozel.
Okay.
Yep. With regard to the needs assessment, I have to step back for a second and just comment on the appreciable change that we've realized on the store over the last 12 years. And that change has been predicated in closing hospitals and converting them to freestanding medical facilities. That change has been creating Maryland's first Maryland Rural Hospital up in Chestertown in Kent County. That was once a full-service acute care hospital, and also creating emergency centers and urgent care centers around the region. A lot of change has been going on over the last 12 years on the Midshore. And in each case, we have sought out and received significant community support for the directions that we've been going in. So much so that when it comes time to share this information with the public, it's usually our elected officials that are local, our leaders in the business industry, and our health departments that are standing with us proposing these recommended changes to our community and getting support for them from the community. When we looked at the Easton Regional Medical Center, the application is complemented with a number of letters of recommendation and support as part of this. We could have inundated you with thousands of documents, literally thousands of letters of recommendations from our community for this project. I sit here before you representing 2,000 team members and 500 medical staff and volunteers, but there are 170,000 people of the Midshore behind me that are asking for, waiting for, and eagerly anticipating building this new regional medical center. And it's all because we've had a clear vision for how the Midshore should be cared for, and we've executed systematically on that vision over time. And that culminates with the request for the regional medical center here in Easton. So a lot of support in the form of written documentation, but behind us a lot of community support for this application, and actually waiting for today's decision for me to call them and let them know about the progress we're making. So.
And I'm happy to address the second question, or at least start addressing, and then I may ask Dr. Huffner, who's on the line, to chime in as well for part of that. But you asked about...
Introduce yourself.
Oh, I'm sorry.
Just for those on the line.
Yes. Hello, everyone. I'm Mallory Regenbogen, counsel for SHORE. And you asked about why pediatric and obstetric beds are being reduced in the replacement hospital. And I'll say, we'll start with the pediatric beds. So SHORE, as part of this project, has very carefully studied all of its utilization, historical and projected, and it's had very low levels of pediatric services in recent years. And as part of this project, it's also looked really carefully about surge and peak capacity and made sure that every service line, it feels like, has sufficient capacity not only to handle the average census, but also a peak census, particularly with the recent challenges of COVID. This is front and center of everybody's mind. How can we make sure we have sufficient surge and peak capacity? So with the pediatric bed that's being proposed, right now volumes are fairly low, and the one bed will serve the population the majority of the time. It's going to be located on the labor and delivery unit adjacent to that, and right next to 2 medical surgical beds. So if there were to be a surge in census, there will be additional.
Okay, take the number. Watch it go across. Okay, yeah, it's right there.
And it's believed with that additional
Then you got to
capacity
put the
that
PIN number, 824-8246.
Oh, someone, go on mute. Go ahead.
Okay, thank you. So next, if there are any questions before I continue with OB? Okay, so for the obstetric service line, you may have noticed that Shore is making a pretty significant change to the model in the way that it delivers obstetric care. So it's currently under an LDRP model, meaning the patient, labor, delivery, recovery, and postpartum is all in the same room. So currently Shore has 3 antepartum rooms, 10 LDRP rooms, so 10 delivery rooms. It's shifting to a more common model for facilities that have a larger number of births per year, which is the LDR model. And so in the proposed replacement hospital, it'll have 2 antepartum beds, 8 postpartum beds, 1 LDRP bed, and 4 LDR beds. So it will have a total of 5 labor, delivery, recovery rooms, as well as 10 for its antepartum, postpartum stay. It did a lot of careful looking at its data and trying to assess in switching models what its peak and surge capacities would look like in each of those areas, antepartum, postpartum, and labor stage. And it feels confident that the mix of beds that it's moving to is going to be sufficient to handle its peak. I don't know if Dr. Huffner, anything you would like to add that overview?
The only color I might add, this is Bill Huffner. I'm the Chief Medical Officer and Senior Vice President of Medical Affairs at Shore Health. And Dr. Blake, thank you for those great questions. The only color I would add is that within the existing Shore Regional Health footprint, we are adding services to expand and improve the care that we'll provide, both for pediatric and obstetrical patients. And by those programs, I'm talking about 24/7 presence of an obstetrician in-house, 24/7 presence of an anesthesia provider in-house. And as of last month, we had 75% of our inpatient pediatric in-house pediatricians present. So we're moving forward now to make sure that as we move into this brand new medical center, we have the correct practitioners present in our hospital to optimize care, but also to expand care. We expect to continue to see growth in the amount of patients that can remain on the shore in these 2 areas. I hope that helps.
Thank you.
Commissioner Boyle, I think was,
Quick follow-up on the obstetrics. What's your plan for maternal fetal medicine care for high-risk patients? Will they have to leave the shore for that?
I may I ask, I'll answer that question, and thank you for bringing that up. I admitted to the fact that we've also hired a maternal fetal medicine specialist who is now working here at the shore, and we hope to be able to retain more and more of those high-risk patients that will not necessarily precipitate transfer. The same also goes for gynecological oncologists, which was another addition to our list group of practitioners that have occurred really in the last 4 or 5 months.
Thank you.
Commissioner Boyle?
Yeah, I just want to comment.
Great questions, Commissioner, and thank you for asking. Short answer to your first question is yes, they will receive the training necessary to care appropriately for those patients. The second answer to your question, is it enough? Again, as Mallory said about other options, there is flex options that we'll continue to offer in the event that it's not. But we believe that based on the data that we have and the current utilization rates and projected rates for behavioral health patients, that it qualifies for what we need.
And where do your, when you have to send patients for inpatient sites?
Part of the existing facility and the new hospital.
On the site, in the ED, there's going to be 2 psych exam spaces that are specific to psychiatric patients. There'll also be the 3 holding spaces that will basically just be a secure holding area while once they've been medically in order to facilitate either inpatient admission at Shore or elsewhere or transfer to another space. Shore currently serves the adult inpatient psych patients. It does not serve geriatric psych patients that have neurocognitive disorders or child or adolescent patients. So those are the patients that are more likely to be held and transferred.
Are there any other questions?
Yeah, hi, it's Commissioner Gelrod. So a couple of just comments, I think, more than questions. One is if the data are showing that the number of beds can be slimmed down for certain services, and you can use your whole system in a really productive way for patients who need more higher level care than what they could get in a community setting, then more power to you, because there are a lot of places that are overbedded and stretching resources. So if you can handle your surge and you can do it with the bed count you're looking at, I really congratulate that. I love the idea that you're going to be able to get to all private rooms. I think that's essential in infection prevention, and that needs to be a leading agenda item in all design going forward. So good for you and the addition of psych. I think it's a well thought out program.
Thank you, Commissioner. That, I'll ask one last time if there are questions and comments, and then I'll call the question. One last shot for anybody? Okay, all in favor of approving the CON for relocation of Shore Medical Center at Easton Shore Health System? Say aye.
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 Are there any opposed? Motion passes. Thank you very much. I hope you enjoyed sitting in the chair spot.
Could we also approve the PCI application? All in favor, say aye. Thank you, I appreciate it.
We'll move on to agenda item number 4. Certificate of conformance for Shore Health System to relocate primary and elective percutaneous coronary intervention services, PCI, at Shore Medical Center at Easton. Shore Health Systems is seeking a certificate of conformance to relocate its primary and elective PCI services to the replacement hospital at Shore Medical Center at Easton. This request is in conjunction with the CON application. Katie Nerrell, Program Manager of the Acute Care Policy and Planning Team, will present the staff recommendation. Katie, you have the floor.
Thank you, Chairman Sargent, and good afternoon, Commissioners. Katie Nerrell here, Program Manager with the Acute Care Policy and Planning Team. I will now present an overview of the staff analysis and recommendation. The University of Maryland Shore Medical Center at Easton has been performing primary and elective PCI services since March of 2017, and the hospital has been able to comply with the standards for certificates of ongoing performance for PCI services. This was last renewed in November of 2021. In its application, University of Maryland Shore Health System also demonstrated on behalf of the hospital compliance with the requirements for certificates of conformance for both primary and elective PCI services. The hospital has been able to perform PCI services 24 hours per day, 7 days a week, with very few exceptions. The hospital has also been able to achieve the door-to-balloon standard for primary PCI services when measured over a rolling 8-quarter basis for the period from July 2019 through December of 2022. In addition, interventionalists who performed PCI procedures at University of Maryland Shore Medical Center at Easton between January 2019 and December 2021 met the minimum requirements for at least 50 PCI procedures annually, averaged over consecutive 24-month periods. As noted in the Certificate of Need presentation, the hospital is meeting the general requirements found in COMAR 102410, which is the State Health Plan chapter for acute hospital services. These standards pertain to providing information regarding service charges, the hospital's charity care policy, and meeting quality of care standards. Although the hospital is performing below average on 4 of the quality measures, the hospital explains the steps it's taking or has taken to address those deficiencies. So one of the key requirements for a hospital seeking a certificate of conformance to establish primary PCI services is that the hospital demonstrate the proposed program is needed and that it will achieve an annual case volume of 36 primary PCI cases for a hospital that's located in a rural area. The applicant projected that the hospital would perform 82 primary PCI cases in 2030, which is consistent with staff's analysis and the recent volume of primary PCI cases performed at the hospital, which was 76 cases in 2021. One of the key requirements for a hospital seeking certificate of conformance to establish elective PCI services is that the hospital demonstrate that the proposed program will achieve a volume of 200 or more times by the second year of providing elective PCI services. The applicant projected 210 elective PCI cases in 2030. Therefore, the total number of PCI cases projected for that year is 292 and exceeds the total volume requirement of 200 PCI cases annually. Another key requirement is that an applicant present evidence that the proposed program's service area population has insufficient access to emergency PCI services and is receiving suboptimal therapy for STEMI. Applicant's drive time analysis, it demonstrated that there would be a clear unmet need in the hospital service area. The current PCI program is not relocated to the replacement hospital. While travel time from the most populous city in each county to the University of Maryland Shore Medical Center at Easton ranges from 11 to 42 minutes, no other hospital serving residents of these counties included in the hospital service area has an estimated travel time of 30 minutes or less for primary PCI services. MHCC staff's own drive time analysis also confirms the need for the PCI program at the replacement. Lastly, the hospital has demonstrated that it engages in quality assurance activities required, such as internal and external reviews of the cases and holding monthly meetings to review issues related to the primary PCI system. The applicant has committed to continue to engage in these activities. With that, I conclude my overview of the staff report. Staff is recommending the approval of University of Maryland Shore Health System's application for certificate of conformance for primary and elective PCI services to be relocated to a replacement hospital with the following conditions. University of Maryland Shore Medical Center at Easton shall apply for a certificate of ongoing performance within 3 years of establishment of primary and elective PCI services at the replacement hospital in accordance with the review schedule published in the Maryland Register. Furthermore, the University of Maryland Shore Medical Center at Easton must continue to comply with the requirements for a certificate of ongoing performance at the hospital's current location. I'll note that there are some representatives from the health system with us today, in addition to President and CEO Ken Kozel and the council, Ali Ledich and Mallory Regenbogen. I also believe that we have both Hillary Castle-Schmidt, Director of Operations, and Dr. Jeffrey Etherton, Medical Director of Interventional Cardiology at Shore Regional Health are also on the phone. So with that, at this time, I'd be happy to take any questions.
Thank you. I'll start with the motion, and then we can have discussion and questions. Do I have a motion to approve the certificate of conformance for Shore Health Systems to relocate primary and elective percutaneous coronary intervention services at Shore Medical Center at Easton?
Dr. Bhandari.
Commissioner Bhandari seconded. Are there any questions? That, I'll call the question. All in favor, say aye.
Aye.
Are there any opposed?
Aye.
Aye.
I think those is all ayes.
Okay.
Are there any opposed? Sorry, I didn't leave enough time there. I'm hearing no opposed. In that case, the motion passes. Thank you very much, Katie.
Thank you.
Yeah, so first off, before the team from SOAR leaves, I want to thank them for their patience. It is true that this is the, I guess, third time is the charm. There have been 3 applications for the beginning in 2012. I want to be sure everyone understands that the commission never turned them down, nor in this application did we reduce the bed request from Shore. That being said, I think it's also important, Ken generously did not recount the hurdles that the state established, not always NHCC, but at the time they came forward in 2012, the response was, now's not the model. You'll have to wait.
We lost our internet.
That's something. Application in the meantime.
And I had to call into the meeting, so.
I think we have someone on the phone that needs to mute. They then went forward with really a conversion of Chester, the Chester River Hospital, Chestertown, to a rural hospital. We asked them to do that. They followed through. We raised concerns, that is, the state raised concerns about the status of Dorchester. Prior to that, they submitted a second CON application. Dor said, you know, we really need to get this right.
Coco, shut it.
Excuse me, I think you're on, someone's on, should be at their phone. We asked them to figure out how Dorchester would be configured. They converted that to an FMS. And then finally, in January of 2023, the third application came through, and I think we've moved forward with that pretty efficiently over the last year. It seems like a long time, but that's, there are lots of questions with a big project like this. Keep in mind that if we had approved, we never got that point. In 2012, the cost of the hospital, which actually I think had a few more beds than what actually is requested today, that would have been a bit under $300 million. This project is going to, estimated cost is about $540 million. Happy to report that yesterday the governor confirmed that funds for this project would be made available over the next 4 years. That Shore has requested $100 million from the state. Those funds will be divvied out appropriately and as needed over the next period of time as the hospital construction continues. All is well that ends well. Might not be quite the story just yet. We still need a hospital out there, but we really want to thank you for your persistence and also the steps you've taken to make sure that healthcare in this important rural area of Maryland is as good as any place else in the state. So thank you for your patience and the best of luck with the project.
Thank you.
Thank you, Jen, and,
Sure.
On behalf of the University of Maryland and the University of Maryland Shore Regional Health, in a great state here, a state that provides us with agencies that's figuring out some of the incredible challenges in healthcare that we have. A lot of what we've done, and I alluded to over the past 12 years, is in large part because of commissions like yourself that gives us the tools that we need to apply them to health. That's all culminated with today's CON application. Just a special kudos and thanks to the MHCC staff. Challenges that exist across the country that we can solve here in Maryland. So, you've been helping us through this process. Thank you also to the Commission for your unanimous approval of today's application. So important to our community to have this facility. Also, I'd be remiss if I didn't mention the governor and the General Assembly. Incredibly generous with his budget for solving rural healthcare in the nation. Tools and techniques that we're using here from this community for the rest of the nation. Rural healthcare is failing across the country, not in Maryland. Because of commissions like this, the HSCR governor that believes and supports in all of our counties with it. Also, the General Assembly and his team that has pulled together. Special thank you to Ben Steffen. Ben and I have worked together over the last 12 years on this project, and incredible professional, you're an incredible gentleman, a scholar and a gentleman, and I just thank you.
Thank you. Thank you. Okay. On to agenda item number 6. Small assisted living programs, study work group, recommendations, and report. During the 2023 legislative session, the MACC was asked to conduct a study regarding small assisted programs. The goal was to... I apologize. Such a hurry today. Agenda item number 5. I'm going to blame the technology, even though it has nothing to do with it. Mandated health insurance services evaluation, hearing aids for adults. Yes, we're going to pause the meeting for a moment. We think we might get...
We want to jump ahead.
All of them are presentations that are remaining. All right, so you can hear me fine through there? All right, disconnect that. Go ahead, shut that down. Okay. All right, can the people on the outside hear?
Yes. Yes.
Yes.
We're good.
Yes.
Agenda item number 5, mandated health insurance services evaluation, hearing aids for adults coverage, HB 1145. Insurance Article 15-1501 Annotated Code of Maryland requires that the Maryland Healthcare Commission annually assess the medical, social, and financial impact of proposed mandated health insurance passed during preceding legislative session or as requested by a legislator or legislative committee by July 1 of each year. MHCC staff received a formal letter of request from the Senate Finance Committee to evaluate the legislation House Bill 1145 introduced during the 2023 session that failed to pass. This fair practice to have MHCC staff contracted with Lewis and Ellis actuarial consulting firm to evaluate 1145, which generally relates to health insurance coverage. Tracy Hughes, the principal consulting actuary with Lewis and Ellis, will present the findings of the study. Ms. Hughes, you have the floor.
Hi, can everyone hear me? I'm sorry,
So you're not hearing her?
Yeah.
Okay, hold on real quick.
okay.
Speak one more time.
Can you hear me? Testing?
Outside can hear you.
I can hear you.
Yeah, we cannot hear you in the conference
Okay.
You have not entered any number. Please re-enter your meeting ID followed by pound. You entered 4887. This meeting ID does not exist. Goodbye. You have not entered any number. Please re-enter your meeting ID followed by pound. Enter your participant ID followed by pound. Otherwise, you are in the meeting now. There are more than 40 participants in the meeting. This meeting is being recorded.
Thank you, Levon. Okay, Ms. Hughes, you wanna,
Yes, can you hear me now?
excellent.
Okay, great.
You're on the floor.
Awesome. Thank you for the introduction. And do I have control on these slides, or do I just need to indicate when when it's time for the next slide?
Just say next, and they'll move.
Just say
Okay.
next slide and they'll move.
Okay, great. Go ahead and move to the next slide. Excuse me, if I cough here and there, I'm getting over a lingering cough, so I'll do my best here. So as they was mentioned in the introduction, Lewis and Ellis was engaged by the commission to address or perform a social, medical, and financial impact evaluation for the proposed mandated insurance coverage for adult hearing aids. We used various publicly available literature, statistics, and other sources. We also interviewed several Maryland providers over 2 different interview groups. Most of the providers interviewed were audiologists. One ENT was also included in the interview. And we also supplemented with data from the Maryland All-Payer Claims Database. Due to the timing of this evaluation, it was a shortened timeline, and therefore we were unable to do an insurance carrier survey as might usually be done for such an evaluation process. But we were able to get the information we needed from other venues nonetheless. Next slide, please. So to summarize what's being proposed, there's a current mandate in Maryland for hearing aid coverage for minors. that is able to be limited by the carrier to a benefit payable of $1,400 per hearing aid for each hearing impaired ear every 36 months. There's also a stipulation in there that if, or guess I should finish by saying for the coverage for minors, there's also a directive that if a more expensive hearing aid wants to be, the insured wants to elect a more expensive hearing aid, they're allowed to do so and pay the difference without financial penalty. The same stipulation with the ability to pay the difference applies for adults if the carrier chooses to provide a hearing aid benefit. So not necessarily mandated benefit for adult hearing aids, but just a stipulation if the carrier chooses to provide such a benefit. What's being proposed would remove the optional language and basically mandate the same provisions that are mandated for minors with the limit to the benefit limit available, as well as the paying the difference being available and that being applied to and available to adults. Next slide, please. I suppose before I hit these highlights, I'll also mention that we did give a full and detailed report. So these, in this presentation, I'm just going to sort of hit the highlights, and any further detail desired can be found there. So just briefly, the CDC defines hearing loss as when any part of the ear is not functioning as it should. Hearing loss is categorized on a spectrum from normal to profound based on the hearing loss measured in decibels, as is summarized in the chart here on the slide. Next slide, please. Hearing loss is categorized into two primary types, conductive and sensory neural. Conductive hearing loss is typically treated with medication and surgery via an ENT doctor. Sensory neural hearing loss is the most prevalent form of hearing loss, and it can be remedied through medicine and surgery, so typically is treated using a hearing aid via an audiologist. And hearing aids are not considered a cure for hearing loss, but instead a device used to improve their hearing ability. Next slide, please. Regarding medical effectiveness, approximately 85% of adults experience no difficulty hearing when using a hearing aid. The remaining 15% still can encounter some minor or major challenges. This is significantly improved from 1990, where the satisfaction rate was more like 60%. Hearing aid use can also reduce other physical health risk factors, such as risk of falling and fall-related injury, likelihood of diagnosis of anxiety or depression, the number of ER or hospital visits, and also the length of stay of a hospital visit. Next slide, please. Maryland currently has about 4.4 audiologists per 100,000 population. It's important to note that any one insurer's participating network consists of a subset of these total number of audiologists. This fits in a nationwide range across all states of 2.1 to 7.6 audiologists per 100,000. Based on our interviews with audiologists, hearing aids are included in the treatment plans for a sensory neural hearing loss in more than 85% of patients. Many times, those that do not have a hearing aid prescribed in their treatment plan have a hearing loss much more mild or slight that they're referred to over-the-counter hearing aids. Next slide, please. Around 15% of adults experience hearing loss, ranging anywhere from mild to severe. However, of these adults, only about 20% actually use hearing aids. This utilization rate also increases with age. So when you exclude the Medicare population and focus more on the 18 to 64 age range, which we did in our study, The utilization rate is more like 10%. Regarding insurance coverage, it's inconsistent and varies by plan, with most not providing hearing aid benefits currently. Based on information from the providers we interviewed and other Maryland specific data, it's estimated that about 20 to 40% of insurance plans currently cover hearing aids for adults. Next slide, please. According also to the audiologist interviewed, about 15% of patients seen by any particular provider may be turned away for because the provider is not within the insurer network. And two major reasons were cited for providers not reaching a contractual agreement with the insurer in these cases. One regarding the allowability of balance billing, as I think in a lot of sort of boilerplate contracts, balance billing is not allowed. And balance billing would allow the provider to bill the insured for the difference between the allowable benefit and the more expensive option. The other reason noted was some insurers solely contract with hearing aid network vendors such as Amplifon or True Hearing. And so that is that encompasses when they contract with such a vendor, that is the only network that the insureds have accessible covered benefits through. So they're required to then utilize those providers through that vendor, and no other provider can contract with that carrier. Next slide, please. Regarding barriers to getting hearing aids or utilizing hearing aids, main reasons cited were cost, under an estimation of the importance of hearing health, lack of awareness about how to get hearing tested or acquire hearing aids, being uninsured, and also accessibility challenges to get to a provider, particularly in rural areas. Next slide, please. Regarding our financial evaluation, L&E leveraged all of the data and information available to us to develop estimates for each variable that could influence cost or utilization, categorizing them into low, mid, and high-end range assumptions. These three ranges are not confined to three specific scenarios, but rather are designed to encompass the various uncertainties inherent in each assumption, and aims to provide a final range that encompasses a spectrum of potential outcomes and scenarios. Each assumption range, as well as the final range, is discussed in detail regarding each assumption, each range, and the data it's based upon in the detailed report. And next slide, please. And the final range we came to for the fiscal impact was 0 to 0.1% of premium, or 1 cent to 74 cents per member per month premium costs. We also note that nothing in the proposed House bill would prevent or limit carriers from making other cost sharing or benefit changes that are not related to adult hearing aid benefits, which could ultimately mitigate or eliminate the impact of the mandate proposed. And that's the extent of my presentation. Thank you for taking the time to listen and the opportunity to provide such evaluation for the commission. I would like to mention my team, Dave Dillon and Cheryl Robison, and please let me know if you have any questions.
All right, with a motion, can I get a motion to approve the mandated health insurance services evaluation hearing aids for adult coverage, HB 115?
Commissioner Jordan, motion to move.
Second.
Commissioner? Thank you. I heard the second. Which commissioner seconded?
Commissioner Gelrud.
Thank you. Thank you, Commissioner Gelrud. Are there any questions? I had one question, and I'm looking at the chart on your report. It was page 15. and you had an estimated lifespan of 8 to 4 years for each hearing aid. And I don't recall from this legislation, was it did the mandate include getting a new hearing aid every year? Or did it limit it by a lifespan of the hearing aid?
Every 3 years, that the carrier may limit it to every 3 years if they want to, but they don't have to.
Thank you. I want it every year.
As additional context to that, according to the reason that we didn't include 3 years as part of the range in our assumption range for that lifespan assumption, is because when we spoke with the audiologists that we interviewed, they said in a large majority of cases, like maybe there would be some exceptions, but in most cases, being able to prove medical necessity for a new hearing aid after 3 years would typically be tough because regardless, the insurance company won't cover it unless they can, show medical necessity.
Got it. Thank you.
Mhm.
That'll change when they put the internet on it. Any other questions before I call the motion? Right. All in favor of approving the report? Aye.
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 Are there any opposed? Ayes have it. The report is adopted. Thank you very much, Ms. Hughes.
Thank you.
Agenda item number 6 for real this time. Small Assisted Living Program Study Work Group Recommendations and Report. During the 2023 legislative session, MHCC was asked to conduct a study regarding small assisted living programs. The goal was to conduct a study of the current state of small assisted living programs and recommend improvements. Stacey Howes, Chief of Long-Term Care and Health Plan Quality Initiatives in the Center for Quality Measurement and Reporting, served as the chair and will present the recommendations for the work group. To the floor.
Thank you.
Great. Good afternoon, Commissioners. MHCC currently has very limited authority over assisted living programs. We also have very limited data to develop policy recommendations for this study, but having said that, there is clear need for services for the population, the aging population of Maryland. An interagency collaboration and cooperation is going to be critical to the success of these recommendations. This was a legislatively mandated study. Conduct a study regarding the quality of care provided by certain assisted living programs and generally relating to a study of assisted living programs. So in addition to a general study, we were also asked to examine 3 different categories of issues falling under the categories of quality of care, costs, and examining the feasibility of an emergency room. The participants in this work group consisted of multiple state agency representatives, consumer and industry advocates, and several representatives from both large and small assisted living programs. Also, I'd like to acknowledge and thank Commissioner Boyle for actively participating in this work group as well. We met 6 times, beginning in the fall of 2022, until our last meeting, which was approximately 2 weeks ago. And we had several experts speaking, which included Dr. Ney from the Office of Healthcare Quality, Vivian Ellis from the Long-Term Care Ombudsman Office, Courtney Barno from the Home and Community-Based Waivers Program, and Ken Lemberg from the Governor's Workforce Development Board. We also had Ruthie Fishman speak to us. She is a current small assisted living provider, and she provided her perspective on the current state of assisted living. Before we began the work group, we conducted an environmental scan. And so, first of all, a little bit of background about assisted living in Maryland. We have over 1,700 assisted living. 1,255 of them are fewer than 10 beds. And MHCC publicly reports quality information on assisted living programs, but we only do it for programs with 10 or more beds. So we are currently reporting on approximately 27% of the assisted living programs in the state of Maryland. Assisted living programs are available throughout the state of Maryland, but small programs are disproportionately available. Most programs, regardless of the size, are in the center of the state, leaving the western, southern, and eastern regions with fewer options. Somerset, if you look at this chart on the slide, you'll see that Somerset and Garrett counties don't have any small assisted living facilities, while Baltimore City, Prince George's County, and Baltimore County have over 830 combined. So some of the conclusions we were able to draw from our environmental scan was that there is no standard definition of what constitutes a small assisted living program within the state or across the state. There is currently a significant gap in the quality improvement benchmarking and comprehensive data collection strategies for assisted living programs. Also, as I just pointed out, assisted living programs are available throughout the state of Maryland, but small programs are disproportionately available. And also, very little deficiency data was available to us for this study, but from what we were able to analyze, the deficiencies tended to fall into just a few categories, and those include other staff qualifications, emergency preparedness, and medication management. And we also learned that a small portion of assisted living programs tended to account for a significant number of the deficiencies found. We also learned that the market is quite volatile when it comes to assisted living programs, with more than 100 programs opening every year and dozens closing each year. Fortunately, there was no additional data for us to drill down on that to learn more, but that is concerning in and of itself. We also learned quite a bit about the cost of assisted living care. It is quite high, you probably already know that, but it's quite high, and the assisted living median cost in Maryland vary significantly by the region of Maryland. They also vary, they're also much higher in Maryland than they are in surrounding states, with the exception of the District of Columbia. Also, reimbursement rates for Medicaid are not covering all of the necessary costs. And the community options waiver has very specific qualifications in order to enroll. Also, the wait lists for those programs are years long. We also conducted a survey of current assisted living providers in the state. We distributed our survey 3 different times between December 12, 2022 and January 16, 2023. And we had a 15% response rate. Respondents represented a mix of new, growing, stable, and long-standing assisted living programs. The word small there is a typo. We actually included all types of assisted living programs, so sorry about that. And key challenges that they identified were a lack of regulatory guidance, infection prevention and control training and resources, specialty training and resources, flexible reimbursement options, and general health care training. They also noted a lack of general health care training. They also noted a need for increased reimbursement for services, and an overwhelming number of the respondents said that cost was a central concern for them, because they said that cost affects absolutely everything that they are doing. So the work group developed several recommendations, and the recommendations were developed with the understanding that preserving continuity of care is desirable for most of the residents. And the recommendations are designed to strengthen our current regulatory system by creating a more efficient and effective data infrastructure, which supports interagency collaboration, effective oversight, and monitoring of performance. The recommendations would require resources from the state, including better monitoring, and the work group supports implementing these recommendations slowly, starting with the very smallest assisted living programs of 2 to 5 beds, eventually extending the recommendations to up to 9 beds, and then to larger facilities. In the MHCC would oversee the implementation. So the first recommendation from the work group is to adopt a consistent definition for small assisted living programs across all Maryland agencies. The group is suggesting 16 or fewer beds to be defined as small and 17 or more beds to be defined as large. If, as I mentioned a moment ago, a residential dwelling with 2 to 5 unrelated individuals would be the focus of the recommendation in the first year. And the commission currently uses 9 or fewer beds as a definition of small, but this number was chosen fairly arbitrarily based on our ability to take on a workload. So the definition of 16 or fewer beds is more consistent with the assisted living licensing application. Next recommendation is in collaboration with the Department of Aging and Long-Term Care Ombudsman Program, the MHCC would conduct a needs assessment to identify appropriate distribution of assistance programs by jurisdiction. The number of programs is changing so constantly that it's necessary to determine the number and size of programs in each jurisdiction to ensure equal access across quality programs. There's general support from the work group for creating a uniform definition of small, prioritizing the smallest assisted living programs first, and conducting a regular needs assessment. Also, the long-term care ombudsman specifically asked to be included in as many of these recommendations as possible, so you'll see that reflected throughout. The next recommendation is that the Department of Labor would be consulted about supporting, establishing, and facilitating employment and training programs specific to assisted living programs. Next recommendation is the Department of Labor and other relevant state agencies shall partner with local community colleges to develop training programs and courses that would encourage the development of a well-trained workforce. The Assisted Living Provider Survey identified a major problem with finding and keeping staff and obtaining quality training, and these recommendations would help alleviate that problem. There was general feedback from the work group to support job creation and job support. And the work group, originally these last 2 recommendations were worded for the Department of Labor only. The work group suggested that multiple agencies would be involved, so they asked to have the wording changes to appropriate state agencies in addition to the Department of Labor. That's reflected in the recommendation. Next recommendation is that the appropriate state agencies shall review and determine necessary changes to the existing training programs for assisted living program managers to ensure full compliance with the provisions of Health General 19-1807. Recently, regulations stipulated that even small assisted living providers must complete the assisted living program manager training course. And there are quite a few options already to complete that course, but it's not clear that the training would be appropriate for small providers. This recommendation addresses that concern. Next recommendation is the appropriate state agencies shall support training programs for assisted living to attain the training they need to attain a higher level of care. Assisted living providers are often responsive to the needs of their current residents who need additional care but don't want to move. And allowing providers to easily access training for higher levels of care would be quite valuable to them. Next recommendation is that Maryland's Medicaid program shall conduct a thorough reassessment of reimbursement policies in the Maryland Medicaid Home and Community-Based Waivers Program. Providers stated that the amount and types of reimbursement were not adequate for them, and this recommendation encourages Medicaid to evaluate the program thoroughly. And the next recommendation is that MHCC shall study ways in which family members can be supported when caring for family with assisted living program level needs. Family members are stretched quite thin when it comes to caring for loved ones with complex needs, and finding ways to support them is critical. So there was general support from the work group to create a comprehensive review of the home and community-based waivers program. The recommendation where we encourage support for family members was worded quite differently before, and they suggested removing the stipulation that we had in there previously and suggested the current wording that I just shared with you. The remaining recommendations fall under the category of technology and data infrastructure. First recommendation under this category is that the state would allocate requisite resources to OHCQ to establish and maintain a robust data infrastructure, ensuring timely, efficient, and accurate data collection. Current method of data collection and the way it is shared with other state agencies and the public is incomplete. Next recommendation is that MHCC, OHCQ, and other state agencies shall formalize interagency data sharing arrangements to support timely and accurate data for quality improvement, consumer decision-making, and program performance monitoring. OHCQ currently has MOUs with some state agencies, but the sharing is incomplete and it's not commensurate with public reporting. The next recommendation is to explore funding options and technical requirements to develop and implement a digital platform through the state-designated Health Information Exchange to facilitate efficient information exchange and data collection and sharing. The platform should include functionality to collect data during a public health or catastrophic emergency. And as part of this requirement, all facilities would be required to maintain an active email address and stable internet connection. And the final
Just a doing business now.
The final recommendation is to formulate a joint committee to oversee the design and rollout of a public education campaign that highlights assisted living as a viable long-term care option, detailing its benefits, costs, and the types of care and services offered. Feedback from the work group from these last few recommendations was that there was general support for making data collection and infrastructure more robust and more accessible to all state agencies. OHCQ did note that they recently implemented a new data system and platform for data sharing that they have recently put into place, but the work group agreed that the recommendations should stay as written because they need to strengthen both interagency data sharing and public transparency of assisted living provider performance. And for the mandate to create a digital platform that was originally written as a mandate to create the platform, but the work group suggested to make it a study to investigate the feasibility of creating the digital. And the final recommendation about the joint committee, the work group suggested extending the committee to raise public awareness for all long-term care services, not just assisted living. So we added language to say that the joint committee should align with the governor's new Longevity Ready Maryland initiative. Next steps are review and action by the commission today. And pending approval, we would submit the final report and recommendations to the governor and the General Assembly on February 1st.
Start with the motion and then we'll get. I have a motion to approve the small assisted living program study work group recommendations and report.
So moved, Commissioner Gilroy.
I think this time, Commissioner Gilroy, you lost to Commissioner Wood. And just in front of you. We have a second. Are there any commissioners who have questions or comments?
This is
Ask you for your impressions of being on the work group.
Well, number one, I want to commend a fabulous job on this again. Acquisition,
I'm sorry, I couldn't hear.
Stepped at it. Sorry, can you hear me now?
Yeah, did you make a comment or ask a question?
I don't quite understand you, but first I'm commending the staff. They did a great job. But I do want to go back to something, even though I was on it, the
I know, I agree with all of the steps and the actions, but the, page 23, all facilities must maintain an active email address and stable internet connections by those respective dates. I agree with, but it seems to me like the small ones, you know, you're talking about January 2028, 6 to 6/7. We may want to consider looking at the possibility of any new assisted living facilities must have an active email address and stable internet connection are actually approved. This is not, you know, getting connected with CRISP, which is going to take longer, but just as a matter of fact, having that ability.
The idea came from reviewing applications prior and wording, but we thought at some point we had envelope to say I care in this.
Well, it seems to me, you know, irrespective of connecting with CRISP,
Oh, no, I
that should just be required.
Yeah. You know, it sounds like a real basic, it is a basic thing.
Right.
I have to start from where we are, I think.
Yeah, I support that. At the minimum, just people need to get an email, like attached to the, hooked to the internet and have a way to be reached.
So I just wanted to, Commissioner Gelrad, was that your comment, or did you have an additional one as well?
No, I had an additional one. I think this was amazing work, and I'm so glad to see it happen. I have to tell you that I have an internal bias, so it's going to come through because when I was a hospital administrator in this county, there were some very questionable small places that patients were going that turned out to be really very troubling. And so I was so happy to see this work. My question is a little bit related to when we're gonna educate the public about assisted livings, which is great to do, it needs to include education as to what to look for, because these are so unregulated and so different from each other, and the quality of the care can really be so troubling, and the public doesn't really know it or understand it or get it. So I would want to see like tips as to what to look for when you're choosing assisted living. And the last comment is, it was interesting to me that our median costs were more than anywhere around us except DC. And so by cost, did you mean the expenses to care for someone or the price of the assisted living? Because I get it, nobody ever has enough money, but it was interesting to me that we have such varied quality across Maryland with the highest cost. So can you just help me clarify what was the word cost? It was the expenses, because Maryland is expensive to take care of people, meaning food, electricity, staff, etc., or was it the price to pay?
Costs referred to the price to the resident, how much the resident is paying to live in the assisted living. Remember that assisted living is generally paid for out of pocket.
Right.
Not much else.
So to me, a little bit it adds insult to injury that we're more expensive than anywhere and have absolutely no way for people to be able to gauge the quality of the place they're choosing. So great work. I think this is absolutely needed in our state.
Commissioner Brzezinski, I think.
Yes. If over 3/4 of the assisted livings fall under the small definition as less than 10, and if we increase the definition to 16, is it meaningful to differentiate between small and large assisted livings, or should, whatever action we take cover all assisted livings in the state?
Our recommendations to address, they are intended to address all assisted livings in a stepwise manner.
Okay.
So we do want, because most of what we're suggesting would benefit all assisted livings. And we want to start with the smallest.
And what differentiates a large assisted living facility from a nursing home? I'm not too intimately familiar with that, but when do you go from, you're assisted living to your nursing home? What's the difference?
It's how much care the resident needs. So, they only go up to, the levels of care in assisted living are 1, 2, and 3, and 3 is the highest level of care. So it's intermittent care and assistance with daily living issues mostly, but once you go into a nursing home, you need regular RN care.
And I would say, Ken, just to add, it's skilled care. So in assisted living, I can't provide a trach. There's certain things, a feeding tube. You got to go to a nursing home to get that and be an assistant.
And is there somebody, regulating when a patient is beyond the scope of care in assisted living and say, your patient just came back from the hospital with a feeding tube, and, now it's time to go to nursing home, or is that just something that patients do on their own? How do we ensure that standard is met?
That would be something that OHCQ would oversee. They license assisted living for a certain level of care, so 1, 2, or 3 level of care. And so if somebody needed additional care that the assisted living facility couldn't provide, they would have to go to
What's to keep an assisted living from practicing outside of their scope?
That's what an OHCQ inspection would be.
And so what that is, they have a medical director, also known as an RN. So larger assisted livings, we have some that sit in, and they're there every day, and they see residents on a 90-day term. You just saw me, but I'm sick, I can see you. Mom and pop, less than 10, that nurse comes every 90 days. If there's an emergency, the homeowner, whoever's running that assisted living, should call the RN. The RN will advise and say, this person can't swallow, this person can't do this, I'm recommending you move this person. Talk to the family, move them to nursing home.
Thanks. Thank you.
Mentioned the governor's order. Do you want to elaborate on that, or?
Well, I can say a little bit about it. So the governor just, I believe it was just last week, released an executive order stating that taking care of the elderly in Maryland and people at the age, not just the elderly, but people at the age, it would be a priority. And we are to align multiple levels of care and types of care to make sure people know what's available to them. And
we see what we've done here has to be kind of aligned nicely with what.
I would agree. The emphasis was on a whole life perspective on an initiative. The Department of Aging was designated as the lead agency. Department Secretary Rokes was actively involved in the assisted living work group, as well as she did pop in on the acquisition work group. But 3 studies that we have done, small assisted living, nursing home acquisitions, and the study on palliative care services, all fit nicely into this broader governor's initiative. Actually, the order came out on January 3rd, the following day, but definitely represents a very ambitious and comprehensive approach to senior. That, my perspective, it's really a broad framework that a lot of what we talk about is healthcare plus living situations for the And as we're talking about, as you progress, the healthcare component becomes ever important, but we can't lose sight of the fact that living situations are extremely critical. You know, my own personal observation is that most people, when they look at situations for their loved ones, want continuity, and while nursing home care may be more beneficial, it is also more costly unless the person qualifies for Medicaid, and they're apt to want to stay in assisted living as long as they can. Well, as we can't forget the fact that, especially if you've been there 2 years and moving people out to a new setting can have a sundowning effect on that person and lead to much more quickly in a less capable setting, one may know.
Oh, you colored it just right. I mean, the only thing I would add is to the group, I'm just inspired and grateful for the work that you've done. I think that was the first group. I was like, I got to jump on that group. I'm see, I was a little late, but I you know, I'm kind of. There's more work to do, though. Yeah, I'm very interested in this work. I mean, it's even personally affected me now as I'm considering for my mother-in-law. So I worked at higher levels in assisted. I see it, and it has an emotional tie to it as well, but absolutely has to be monitored at the lower level. There's some horrible stories of just not being treated right, close to death, and nobody's monitoring, just hide under the radar. And so for us to be very cognizant and sensitive and understand, it's going to be great. I anticipate as we matriculate through this, the feedback that we get and the hair and the eyes that we raise. You know, I'm very interested to see how this goes, but I think we're playing in the right sandbox.
Any other commissioners with questions or comments before I call the question? Great. Do I have a motion? Oh, we got a motion. All in favor of approving the Small Assistance Living Program Study Work Group recommendations and reports, say aye. Aye.
Aye.
Are there any opposed? Ayes have it. Report is adopted. Thank you very much.
Thank you.
That takes us to the action items. We have a presentation, agenda item 7, where the cost, commercial and Medicaid episodes. December 2023 marked the launch of Where the Cost 5th expansion, featuring 8 new episodes for the commercial sector and 14 for Medicaid. Overcoming numerous hurdles, the MACC team effectively updated the website with the latest data. Mahi Kanjit Solomon will provide an update on the project's progress, along with key background information. Mahi, you have the floor.
Thank you, Chairman. Good afternoon, Commissioners. Today, I'm excited to share with you the latest updates of the Where the Cost, our episode-based price transparency initiative. Let's dive into this. Next slide, please. So, in order to understand where we are today, let's start with some background information, and I think this will be helpful for our new commissioners. MACC launched Where the Cost website for episodes of care in 2017. The website was aimed at and is aimed at primarily educating consumers, industry stakeholders, and practitioners. The website uses Prometheus software covering over 90 different episode definitions. Software actually allows separation of costs of typical care from potentially avoidable complication costs. It allows the website to report on cost and quality results at a hospital level, with a breakdown of, looking at the service category and path costs. Quality indicators are also reported, which includes the total cost, the path rate, and the readmission rate whenever it's available. So now looking at the timeline of our releases, as I mentioned earlier, in October 2017, we launched with the inclusion of 2014-2015. There's a typo, I apologize for that. The study window is 2014-2015. That covered 4 procedural episodes. And in July of 2018, the website was relaunched with a redesign and also the inclusion of 2015-2016 data, in addition to an online appeal feature, which allows the website with consumers. So in 2020, there were 6 additional episodes. for the study window of 2016-17, which brought up the total to 10. And in October of 2021, 3 additional episodes were included for the study period of 2018-19, totaling to 13. This included tonsillectomy with a plan of adding more outpatient episodes in the future. So most recently, as of last month of last year, we added 8 more episodes for the commercial cohort and 14 new episodes for the completely new cohort, which is Medicaid. So looking at the episodes themselves, as I mentioned earlier, for phase 1 and phase 2, we carried the 4 episodes, and then in phase 3 we added 6 more episodes, and in the phase 4 of the release we added 3, which brought the 13, and then with the release from last year, next slide please, we added significant number of episodes, bringing the total for commercial to 21 episodes, and Medicaid is the new cohort, which had 14 episodes. So where the cost has gained recognition and has been featured in news outlets such as the Health Affairs, the Kaiser Health News, and others. Slide, please. And moving on, looking at our communication strategy, it has significantly evolved over time. And initially, we focused on Facebook and other social media platforms for communication and outreach. We continued to engage our audience through organic and paid social media campaigns on Twitter and Facebook to promote and facilitate the conversation. In 2020, we performed a standard research to reevaluate our strategy to align with the health information-seeking behavior of Marylanders. So based on the findings, we made a strategic shift, focusing our, this is in 2021, focusing our budget on programmatic and search ads to raise awareness and educate consumers and quality information. So overall, data has been the driving force in shaping our strategy, which allowed us to refresh ads and add creative and make cost-effective insights. This is an ongoing process, also applies to the current release as well. So moving on to understanding the challenges, we need to acknowledge some of the challenges that we have faced in the past. The first one being the attempt to include Medicare data, and this was back in 2018. And challenges, the terms are a bit technical, but we had issues with the reliability score being unusually high and a large volume of orphan episodes. The existence of these orphan episodes didn't enable us to move forward. In addition to that, the project went through various vendor changes, which presented its own set of hurdles. So we started out with HCI3 in 2017, and then Alterum in 18, Remedy Partners in 19, Signify Health in 2020 and 2021, and now we're working with Change Healthcare in 2020. So in our current work and looking into the near future, we have successfully completed the Medicaid and Commercial 2020 and 2021 release. We are currently working with Change Healthcare on a multi-year contract to further our work. And in the near future, approximately by mid next month, we are working on including acute episodes for the same year, which is 2020-2021, and some redesign of the website. So as we move forward, we have some future considerations with regards to the grouper itself. So originally, Prometheus Grouper was chosen due to its that it's an open source, but due to the multiple acquisitions that, as I mentioned earlier, now the software has shifted into a proprietary domain. So currently, there's no open source episode product available that's thoroughly tested and utilized in the market for us to use. So we know that companies like 3M and Optum have proprietary products, and with the acquisition of CHC by Optum, we have been reassured that the CareCare product will just be integrated and still remain as an independent product within Optum. So that's and also the other positive side of the group is that Maryland CareFirst and sister agency KCRC currently uses the CHC grouper, which is originally Prometheus. So those are pluses for continuing product. Exactly. So to wrap up, where the cost has undergone significant expansion and evolution since the inception, our dedication to educate consumers remain unwavering, and we have faced challenges and overcome them, and we have exciting plans for the future to include more non-procedural episodes and with some redesign of the website to accommodate needs. So I conclude my presentation with that.
Answer the questions?
Yeah, thank you for a great report. I mean, I think the transparency is great. I'm curious, is there any data on the impact this is having as organization? So the way we are evaluating that is, as I mentioned earlier, the various studies that we have performed regarding how Marylanders are currently seeking information from the website. That has informed us that Marylanders are active information seekers. They actually Google for this information. They don't actually wait for, Facebook ads to pop up or something that is pushed towards. So that is what's informing our campaigns as well. But regarding actual, tracking actual patients, whether they go to the website and then make decisions, we have provided the tools. Like for instance, a patient could download, let's say, if a person is looking for hip replacement surgery, they'll be able to go to the website, click on the hospitals within their area, and then download their report, and then just provider to decide which one they could go to. So that would be an area for us to really explore and understand how they are utilizing and tracking them. But that part we haven't been able to do. We're just gauging from the perspective of audience that is coming to the website and how Marylanders are actually looking for information as a whole. That's what we've been looking at.
Any other questions or comments?
I have a question. This is Commissioner Blake.
Go ahead.
Hi, thank you again for the presentation. I'm curious to know, are there any plans to share results beyond the hospital level that includes other health facilities?
So the website reports 4 different service categories. So there's the inpatient cost, the outpatient, the pharmacy, and the professional. So those are the other types of costs that are included. But the episode itself, and then the episode itself includes the cost of, pre-surgery and post-surgery as well. So all these cost information is clubbed together, and then the actual episode is attributed to a hospital where the surgery occurred. If we want to look at, drill down and see where the different types of cost information and who the rendering provider is, all those information is available. And we actually provide this information to hospitals, like the underlying detail, before publishing it to the website. They'll be able to look at when the surgery occurred, who performed it, meaning the rendering provider, and then partial information on the patient. This is date of birth and then the actual diagnosis code. So they'll be able to match that with their system and validate that surgery actually occurred within their.
Actually, Mahi kind of answered the question, which is maybe a little bit of a description of, this is basically all built on insurance claims. Everyone knows that when you actually get anything in the healthcare system, you typically get billed by the hospital or a facility provider in some cases. Surgery center, you have the, as the term Monty used, rendering provider, usually it's a physician. Then there's, you may be given some prescription drugs, a third type of provider. As part of the episode construction process, that information is all aggregated. But there are some tough calls sometimes, that's why you have these groupers, is, you know, do you consider a visit to a urologist in a cardiology, if you're looking at the eye, which wouldn't be something you would expect, that occurred simultaneously. So there is some decision-making building these episodes that has to go on. I want to commend Mahi. She's really stuck with this through thick and thin. Her slide that we've gone through some transitions really minimizes the hurdles that she, as well as our attorneys, have gone through with, you know, repeatedly negotiating agreements and data sharing arrangements and delivery dates for now 5 different vendors. And keep in mind, the goal that providers wanted is, we want something that is open source so we can see how these black boxes actually work. The dominant groupers in the market today are the ones sold by Optum and 3M. The advantage from this originally was it was source and quite a bit cheaper to use. That's kind of changing, but we're reluctant to change groupers because the whole apparatus and changes historical data have to be so we hope that we can work this out with now, you know, Optum / Change Healthcare component. Very helpful that CareFirst is involved with this. We're not under a joint contract or anything like that, but the fact that another, you know, very significant Maryland operator is using this, as is HSCRC. The last question about what's the impact of this, you know, I always say, you know, transparency and shopping for healthcare is, you know, it's still very much a work in progress. People do not shop for healthcare like they shop for shoes, fortunately, or maybe fortunately, but that's just not the way it works. You know, and oftentimes, when you need healthcare, you're in a situation where you don't have time to shop. So we've been very deliberative and episodes where shopping could take place. We can't say that it does take place, but we do know that the greatest impact is that the hospitals themselves pay attention to this.
Hi, I'm
And are interested in where they stand.
And
I think it's
I
impactful
was just away. I'm a bit worried about the weather. I was wondering if it could.
So I'll stop there if someone else seems to want the floor from the phone. But, you know, it's something we continue, but the challenge of engaging people to shop is one that's going to be with us for some.
Last questions or comments before we let Maya go? Very much. Thank you. Agenda item number 8, the legislative update. Tracy DeShields, Director of Policy Development and External Affairs, will provide an overview presentation on the 2024 legislative session. 2024 legislative session of the Maryland General Assembly began on Wednesday, January 10th. Tracy will give us a general overview of the legislative process with a specific focus on the role of executive branch agencies.
Good afternoon, everybody. Good afternoon. Thank you. So the legislative session, as just mentioned, started last Wednesday. The President of the Senate, currently Senate President Ferguson, was reelected, as was the Speaker of the House, Speaker Adrian Jones. So that's always kind of nice to see that sort of like finality with the start of the session. It gets all jazzed up, pretty much. It's a 90-day session. It goes pretty quick. Sometimes for some of us, it goes fairly slow. And it can start with a bang. Generally, the legislative session, about 3,000 bills are introduced. They're probably on track for that this session, probably more. There have been significant numbers of departmental bills submitted, more than I think historically have seen over the years. Next slide, please. So as you know, for the past 3 years, we've been dealing with the remnants of COVID and how the legislative session will function, namely committee hearings on bills and budget hearings. This year, it's more of a normalized process, although they're continuing to have hybrid hearings for those. However, they are limiting the number of people online who can testify. Certainly, people can submit hard copy or written testimony or on bills. So, move along. Next slide, please. Next slide. So for MHCC, most of the legislation that we deal with really comes in two main committees, but our budget is in the Budget and Taxation Committee and House Appropriations. Senate Finance and Health and Government Operations, many of the issues that we follow and address fall in those two committees. So they do have a wide breadth, if you will, of subject matters that get covered in those committees, and we work very closely with them. Usually interim work or sometimes general requests during the legislative session. Next slide, please. So just some dates of interest. Obviously, January 10th is when the General Assembly convened. January 7th, which was yesterday, the operating and capital budgets were introduced by the governor, and he's very excited about the budget moving forward. I generally think the legislature is as well. They usually brief them before they have the formal press conference on the budget, saying sort of what items are in there. We haven't, because it was introduced yesterday, we haven't done a thorough review of exactly what's in those budgets, but for my next briefing, I can update you if there's anything of interest or note for the commission. February 5th and February 9th are what they call introduction dates for bills. So legislators have in the Senate, it's February 5th. So that's the deadline for them to introduce a bill without it going to the Rules Committee. And a lot of times you really don't want a bill to go to the Rules Committee because it can be difficult to get out of rules. And namely because there may not be time for that committee to be convened. So that's sort of the inconvenience. I have had to stand in the room so that if somebody would come in and say, okay, you're trying to get a bill out? Yes, I'm trying to get a bill out. How do I do that? And so usually you have to follow up with the chair. And they actually convene, but a lot of times you'll see people in the delegation room or wherever that committee's going to meet waiting because they want somebody to come in because they have a bill that they really have to get out. So, and in the House, that deadline is February 9th, which is a Friday. And then March 4th is what they call suspension of the rules. And that's the last day that you can do it. After that, it's like, not that things can't get introduced, but it's likely that it's probably not going to be introduced and scheduled for a bill hearing. And the 18th is crossover, so bills in the House have to be in the Senate. Senate bills then have to be in the House. Some of them do lag, they go over late. And, you know, had bill hearings on the last day of session before, so it goes pretty fast. They have April 1st this year, April Fool's Day. I don't know, you can take that for what you want, about the budget being passed, so, you know, somebody could jump out and say April Fool, whatever. But, they've had, the budget passed on April 1st before, so we'll see. And then, the last day of the session is April 8th. Thank you. So just a couple of dates of interest. January 11th in Senate Finance Committee, we did a briefing. I don't know if Ben wants to talk about it at all, but anyway, we did a briefing for them basically on our interim work. So there was a presentation about the nursing home acquisition report, small assisted living report, talk about CON. No. There were 5 others. Oh, and the mandate studies. And then coming up next Tuesday, we've been asked to appear before the House Appropriations Committee to talk about the work that's being done with MHCC and MIMS related to the Maryland Commission on Trauma Services funding. So to really sort of talk about what that commission has done and sort of essentially where they are with recommendations on trauma funding going forward. Next slide, please. February 15th, and then February 19th, February 15th, we have our budget hearing along with the other regulatory commissions in the House Appropriations Committee, and then in the Senate Budget and Taxation Committee on that Friday, February 19th. Next slide. Monday, thank you. Great. And they're on that before too. Yes. So just some issues that we will be following this session. Obviously, legislation dealing with the acquisitions of nursing homes, trauma center services funding, healthcare delivery models, health insurance coverage expansions, mandates, behavioral health issues, and any new payment models. So with that, I'll just mention that as we move forward, we will be informing you there are no bills at this time that MHC that are scheduled for a hearing that we're really following that we need to bring to you as commissioners. But what we have on Thursdays at 8 o'clock is a standing legislative policy call. The first one will be next Thursday. We will let you know whether or not that call actually proceeds. At this time, it may right now. So bills are being added every day, so certain things could come up where we'll need to conference with you and make a recommendation on a position on that bill and then moving forward with that. Schedules this year are pretty tight, pretty quick. There could be times where we can't consult you ahead of time and we have to tell you after the fact we weighed in on a particular bill. Sometimes we're asked to weigh in immediately, or there's just some sort of urgency to how without coming to you all. But there'll be some sort of communication with you around that ahead of time as best we can. So, and then with that concludes my presentation unless you have any questions.
Primary care on
I can have that, yeah.
Is where it also might fall into some of those other categories.
I don't know that there's
Well, the AHEAD model.
the AHEAD model has come up, but not like, right.
CMS model and solicitation was out really remember a copy of that. The state made a determination in December that they were going to be competing in the first cohort, which those proposals will have to be submitted on a fairly rapid turnaround, I think late March, with awards by CMMI by early within a 1.5-year ramp-up period, because, in the first cohort, I believe there are 8 or 9 states that they will select. Maryland, Vermont, and some parts of Pennsylvania are doing much of the work on global budgets already, but the other 5 states that would be starting would really be starting from a very low platform, so thus the need for a ramp up. And for Maryland, it's good too, because we can let the current model play out a little further, which would likely prepare us to meet the requirements of the AHEAD model anyway. So the award's going to come quickly, but then part of the model is, I believe, 2020. Maryland, we still have the predecessor model, which is the total cost of care model, which includes primary care initiative program that Dr. Blitzen is in, but it's also on. So, yeah, as right now we don't see that directly. I think there's going to be more workforce interest, how that's going to play out across.
But will embracing and implementing the AHEAD model require any legislative action?
I'm not sure if it, there was a hearing yesterday.
There was a briefing yesterday in Health and Government
I'm not
Operations.
sure if it will or not. I mean,
Correct.
I think we have the broad confines of what's needed already in place, because we've been doing the total cost of care model for, and the predecessor model for more than 4 decades. Have that flexibility, you know, all the things about the new models. There's a key decision that was agreed to by the O'Malley administration in 2012, which was the old model was in federal law in the Social Security Act, which was, you know, kind of almost said, CMS, keep your hands off it. Maryland's doing its own thing. We gave up that in order to keep the model, but we converted it at that point to a demonstration, which means if we don't meet the requirements of the demonstration, it's taken away from us and we become regular old Medicare. You know, one story that I have, prior to coming to the state, I worked for an organization called ProPAC, which was a predecessor of MedPAC. But when we did analyses, we would always say, drop out Maryland, New York, Massachusetts, and New Jersey, which at that time there were 4 states that had something like what Maryland has, even up to this point, with the Republican administrations in the 90s. All these other 3 states decided they didn't want to do it anymore. Maryland continued, but, you know, it became much more difficult to meet the requirements under that old model, and in order to keep it, we had to say, okay, we'll be under a strict test. If we fail, we give up. We gave up some the authority that Maryland had ended in 2012. To date, we've been able to keep the model. What I would say is that after many years of our friends at HSCRC telling teachers that previous model led to a $2 billion fund transfer from the federal government to Maryland, which was good to tell the legislature, but not necessarily what the federal government wanted to hear. They finally got the message, and not a factor, but, you know, I always disputed whether there was that much savings through the model. There was some, because everyone paid the same in Maryland, unlike what's going on in the country. But we are under a lot more possibility that we would lose this if we don't perform. What's happening under AHEAD as well is I think there's recognition that well over 50 demonstration projects, demonstration models have been launched since the establishment of the Affordable Care Act in 2010. The administrative headaches for claim processors and other entities that are in that business of paying Medicare claims. Dr. Baczynski can attest to this under the MDPC model. There are different payment formulas, but the MACs, the claim adjudicators, have all sorts of new rules to implement, and unfortunately, sometimes mistakes are made. So I think the movement toward AHEAD, which would ultimately be kind of the premier model across the country, if administrative complexity of all these models is going to be probably significant. And, another side benefit is that the Maryland total cost of care model is one of the models that CMS points to as a fact, a success. Not all other models have been successful. They're drawing from where they see success and trying to do it nationally. A little bit of information, more to come on this going forward.
Any other questions from the commissioners, or we could go on to our last agenda item?
I was trying to.
I'll hold everyone until 5.
Until 4 o'clock. I appreciate your indulgence with our technical problems, but I want to call out Levon Ward. Now, I will say this, that you can fix problems when people are looking over your shoulder, and we all can attest how much more difficult that is. So, Levon, I didn't see him get a red face or start shaking, and he got it done. He had to go through a couple iterations where bringing us back to reality. So thank you, Levon. Really appreciate it, as well as Madeline and Vincent involved as well. I don't know, but thank you for your team work. It worked out, I speak frankly, as well as could be expected given the challenges. So thank you. Next month, as I mentioned, we're going to be sending out a survey to the commissioners. As you noted from Tracy's presentation, that we have a budget hearing on the 15th that would be something that chairs don't attend, but the executive director would have to attend. And I would avoid it with great hazard. So I think we should change the date that works well with the commissioners. Chairman's is moving it back 1 week to the 22nd. We'll send out a survey of whether in the morning or the afternoon works best for everyone. I would expect there would be a few more people would want to attend virtually. We had planned to share the Microsoft Surface devices with you that time. We'll have to rethink that in terms of what packets we get from there. It may be that we have to stagger the release with people. Our test engine, the rest of you get it in March. I want to talk with Levon about our approach given what in terms of what's on the agenda. I hope that
I did. Upcoming.
Yes. We'll have one CON action. This is just a request for a project approval change. And then we have action on our surgical services state health plan chapter. We'll have some new nominations for the MD Advisory Council. Tracy will have a legislative update. And then I've asked Tressa and her team to do an update on some of the quality initiatives, as well as to addressing one of the points that Boyle made about what's not specifically where the cost, but the broader quality initiative, but hold everything together. And we'll also have the new executive director of the patient safety present a short overview for priorities going forward. If we have time, I'll also give a short update on the strategic progress in meeting the strategic plan that was agreed to in 2020. And I know last year they maybe heard it, haven't had a chance.
Thank you, Ben. Thank you, everyone, for your attention and flexibility as we work with our telephones and internet. Thanks to the staff, Levon, for closing through. And I'll take a motion to adjourn. I'll move to adjourn. All right? We just can take the motion. All right.